I have to say it's been a massive pleasure for me to be involved with this IMI case study. I think probably quite a lot of people on the call are tuned into rheumatoid arthritis and what it is, but in case there are some people who aren't, as a group, we thought it would be helpful to just have 5 or 10 minutes at the beginning as an introduction to rheumatoid arthritis. And so that's what I'm going to cover. Next slide. So rheumatoid arthritis is quite common. It affects about 1 in 100 people. It's more common in women than men. And it's a disease, of course, of the joints, but the part of the joint which it actually is targeted in rheumatoid arthritis is the synovium. If you look at the cartoon on the left of the screen as you're looking at it, the synovium is the bit which I've circled in that with that black oval. And normally in people without inflammatory arthritis, without rheumatoid arthritis, it's actually a really thin structure. It's maybe just a few cell layers thick. It functions to produce the normal lubricating fluid that helps the joint move. In people with rheumatoid, the synovium becomes really inflamed. And so if you look at that picture on the top right, that's a picture of the synovium of a patient with rheumatoid arthritis. Now that little bar that I've put there is about the thickness of a normal synovium. So if you then look at the synovium of someone with rheumatoid, you can see that it's massively thickened, massively inflamed. And what that translates to in terms of what a patient experiences is what you can see in the photograph of the hand. So the joints become swollen, and you can see the knuckles swollen there. The next slide. So of course I showed you a picture of a hand that was inflamed, but actually one of the main problems in patients with rheumatoid is that the disease spreads to multiple joints, and illustrated here are really the range of all the joints that can be affected in someone with rheumatoid. And when the joints are affected, they become painful, they become swollen, they become stiff, function becomes a problem, and patients feel very tired often as a result of the significant inflammation that they experience. So next slide. So of course that pain, swelling and stiffness is a major issue in its own right, but one of the complications we worry about as a result of long-standing active rheumatoid arthritis is that the joints can become damaged. And if you look at that middle panel there, there's an x-ray of the hand joints that I've illustrated. And if you look carefully at that x-ray, you can see there's 2 little upward pointing black arrows. And those little black arrows illustrate bits of the bone which have been nibbled away by that inflamed synovium. That synovium, which now is illustrated in that picture just below the x-ray, that inflamed synovium eats into and damages and destroys bone. And over time, if not really properly treated, rheumatoid can cause a lot of problems with the joints and a lot of damage and destruction, as illustrated in the photograph on the right. So next slide. So that's the joints. Actually, another problem in people with rheumatoid is that the inflammation can spill out of the joints and affect other bits of the body. One of the things that we particularly worry about is inflammation affecting the blood vessels. And so actually people with rheumatoid, particularly poorly controlled rheumatoid, can have heart disease. And in fact, some people have premature heart attacks as a result of poorly controlled rheumatoid. And the picture on the right, the x-ray on the right, is showing a collapse of a vertebra in the spine. And this kind of osteoporosis and fracture is another problem that people with rheumatoid can experience. Next slide. Fortunately, there's a lot that we can do to help manage rheumatoid arthritis as a disease. And a lot of what we can do has really, well, our new treatments, our new understanding about treatments has come about as a result of our understanding of mechanisms of disease in people with rheumatoid. So what's actually causing that inflammation? We have a good understanding now of the different types of cells which contribute to the inflammation. And as a result of that, a lot of new treatments have been developed which can target inflammation in people with rheumatoid. And that table below just illustrates a few of the many drugs we can use. Steroids, glucocorticoids on the left are cheap, quite widely used, but have quite a lot of side effects. Conventional disease-modifying drugs like methotrexate, also quite widely used. As we move to the right, we start encountering drugs which are even more effective, but actually very expensive. And the drugs in that last column, the JAK inhibitors, are a class of drug which you'll hear about a bit more in Karin's talk. Next slide. So over the last 20 years, there have been huge advances in treatments for rheumatoid, and the lives of millions of people have been transformed as a result of it. But there are issues with the treatments. The first is that all of the treatments are associated with potential side effects, some mild, but actually some potentially very severe. The treatments are troublesome in that most of them require regular monitoring. Some of them are taken via routes, which can, for some people anyway, be a bit of a nuisance. They have to be given by injection, or patients have to come into hospital for infusion. And some, particularly for the drugs towards the right-hand end of that table, the biologics and the JAK inhibitors, are actually very expensive. So next slide. So that's about rheumatoid. Karen's case study is going to focus on people's views about drugs to treat rheumatoid itself. But of course, ideally, we wouldn't want people to have rheumatoid. We want to be able to prevent people from getting rheumatoid in the first place. And the case study that Marie is going to present is focused around people's views on preventive treatments for rheumatoid. Now, in order for you to be able to prevent a disease like rheumatoid, you kind of need to understand the phases that people go through before they get rheumatoid, because if you're going to prevent it, then actually you're going to need to have to intervene in one of those at-risk phases. And over the last 10 years or so, we've developed a really good understanding of some of these at-risk phases, which this cartoon illustrates. So if you look at the far left-hand end of it, you've got someone who's actually completely well, but they may be exposed to risk factors for rheumatoid, including, for example, smoking, or carry genes which put them at risk of rheumatoid. Some people at risk of rheumatoid then start developing antibodies in the blood associated with rheumatoid. They feel fine, they don't have any problems with their joints, but actually if you took a blood sample from them, you'd find that they had antibodies associated with rheumatoid in the blood. Some people then start developing joint pain, but no swelling. Then some people start developing a little bit of swelling, and then some people develop full-blown rheumatoid. So you can see there's those phases 1, 2, 3, 4, which are all phases which define individuals at risk, and actually you could potentially intervene in any of them to prevent someone getting to the far right-hand end of the cartoon journey, and that's what Marie will cover. So the next is actually my final slide, which is to say that although drugs to treat rheumatoid are really, really well developed now, there's many of them in widespread use in clinical practice, this prevention space is a newer one. There's a lot of studies going on at the moment looking at drugs to prevent rheumatoid arthritis. A lot of the drugs shown here are drugs that we use to treat rheumatoid, which we're looking at in at-risk phases to try and prevent rheumatoid. And so clearly it's important to try and understand what views of people who might receive these drugs are about preventive therapy. And I'm sure you'll enjoy hearing Marie speak about that.